We are going to be talking about vision and hearing, two areas that are of particular interest to me. But before we get into that, we had a case study that was sent out to you. And so we're going to go to the case study. I'm just going to, you'll still hear my voice, but I'm going to mute my camera while I go back and forth. But if you have, let's see, let's look at the case study together. Over here. So the case study questions that, or the case study that we looked at tonight involves Sophie. And Sophie is a kindergartner who came to school identified as a child with a developmental delay. Sophie is the only child of a young single mother with limited financial resources. Sophie's shy and quiet and tries to keep to herself. She enjoys simple games and hand activities where she can be successful. As Sophie use her vision in the classroom, she has been noted to laterally collect to the right. Oh, one moment. Make sure that unless it's your turn to talk, you have your microphone muted. So the first people who are going to be talking, let me just, the first people who will be talking are Kasia and Nicole.
Okay.
So, hey, and so when given a quick screening of her visual motor skills, Sophie is noted to have difficulty with visual tracking, saccades, and accommodation because her right eye appears to react more slowly. So Kasia and Nicole, if you might take us through how Sophie's visual difficulties may affect her occupations.
Okay, so Nicole isn't here anymore, so I'm going to speak on that. So I wrote down, because vision helps us to understand and interpret information about everything around us through feedback from our senses, Sophie's visual impairments may affect her speech, cognitive, motor, and perceptual skills, which may affect her occupations. So Sophie's gonna probably have some difficulties in school, which I don't want to elaborate because I think Ruben has to talk about that area. But I will talk a little bit about the difficulties with dressing. In the book, it gave an example of maybe having difficulty with balance when standing on one leg to put their pants on, maybe having some trouble getting in and out of the bathtub, as well as difficulty in regards to feeding when directing the spoon to the plate to scoop the food to feed self. And also some issues in social participation, which will have difficulty initiating and sustaining play activities, interacting with peers because of the slow or lack of visual information to determine the context of the interaction and how to imitate and change activity. So those areas may be impaired because of the visual impairments.
Excellent. Thank you so much, Kasia.
Okay.
And so we will move on to the next area, which is the education. So Kelly and Ruben, how might Sophie's difficulties interfere with her education?
So yeah, in the education portion itself, with her having developmental delays, I basically said that she'll have problems as far as like keeping up with the students that are in her class. So her educational, as far as like her educational process in that aspect will be a little bit delayed, and she won't be able to actually keep up with her peers. Also, with her having problems with the visual motor skills, she'll have problems looking at the board and actually trying to comprehend things, as well as with her developmental delays, which will set her back as far as her educational standards.
I said the same thing, that she's going to have some trouble looking at the board. She might also have trouble reorienting back to the paper and to the blackboard once the teacher's talking, to focus on distance and then to focus near to right. And that could have a significant impact on her education.
Right. Thank you very much. Our next question is to Miriam and Samuel. What remediation activities might be appropriate for Sophie to improve her ocular motor skills?
Since Sophie has difficulty with accommodation and visual tracking, I recommended one games that we give her a large beach ball with word on it. Once we draw the ball to her, she will read the word that is closest to her hand.
Also, since we need to focus on enhancing self-care skills, promoting socialization and participating with peers, we need to come up with games that will engage her to play with peers as well, like ball toss, and having Sophie track the ball or the balloon, hopscotch, as Mariam said, tossing a beach ball with words on it, and ask her to read what the letters or the words are. She could play also with another child, Zoom ball, and ask her just to keep her eyes on the ball, or toss a beanbag in a target, just to improve her oculomotor muscle strength.
Excellent, both of you. And so I just want to make sure that as we go forward with the accommodation strategies, could somebody chime in? What's the difference between a remediation and an accommodation?
Is an accommodation person specific?
So accommodation is for specific to the person to accommodate for a potential deficit they may have. Yes.
Okay.
Accommodation is more focusing.
And that's focused on remediation. What does that mean?
Accommodation is focusing near and far.
No.
And objects.
So accommodation is going to focus more on the way that Sophie accesses her education, her environment, where remediation interventions are going to be specifically focused on improving her skills. So Miriam and Samuel, like you were noting, the different activities that you could do to build her ocular motor strength, that is helping remediate her skill.
Okay.
Where an accommodation is directly referencing how she is interacting with her environment, but supporting that interaction where Sophie is in that moment.
Okay.
All right.
Okay.
So the next question. Go back. Parth and Shayna, what compensation adaptation strategies might help Sophie in common kindergarten activities?
Okay, so a couple of things that we could do. We could change her seating so that she's closer to the board. So, she's not straining her eyes as much, and visually she can see things that are closer to her. We could adjust the lighting. That could be maybe in the entire classroom or her specific working area. Possibly make the lighting a little bit dimmer. Copying your in work from a model. Using a darker marker, darker fonts, and larger font sizes. Placing things on the opposite side of where she tilts, so on her left side, so she's not tilting all the way to the right. Giving her more time to complete classroom activities. Giving her more time to process classroom instructions. Using a slant board for any writing tasks. Encouraging when playing to use cars, roll balls to help increase visual tracking skills. And I think Shayna is going to give you the rest.
Jana, do you want me to unmute you? Yes, I'll do that. Hold on. Oh, it really was muted. Try one more time on your end, Shayna. Oh, there it goes.
Does it work now?
Yes.
Okay. Another adjustment could be using headphones if they're listening to a story rather than having to look at the words. Using like picture find activities to work on tracking and scanning. Developing a visual tracking program to work on. Within the classroom, providing work bins for her folders and her worksheets so that there's less visual distraction for her to have to find those places. Using more pictures rather than words. Using adaptive paper if they're doing any type of writing with bolder lines or raised lines that are a little bit more tactile for her to be able to feel them. And allow rest breaks because her eyes will fatigue quicker than the other students. And then as she gets older, she might need more accommodations where she might need more things adapted on the computer, like a talk to text program or a computer with larger font or a magnifier if her vision doesn't improve.
Excellent. Thank you. So I want to reinforce this that I think it was Parth was talking about placements of maybe a book. And so if you're accommodating, you might put that on her preferred side to help prevent those things like eye fatigue and really kind of help Sophie to access that material in the simplest way possible. But if you were doing a remediating intervention, you would place it on her non-preferred side to really activate those muscles and have her engage with those muscles and kind of challenge her a little bit. So does that distinction feel comfortable?
Yes.
It's starting to, yes.
Okay, good. So our next question, I believe, is for Caitlin and Crudy, and it asks what referrals might be appropriate to help Sophie's visual challenges.
So I guess I'll go first, but this is kind of a basic question I thought. But, an optometrist or a physician, but I know with her being a single parent and all, that maybe the child could be receive services through Individuals with Disabilities Education Act. So I thought that was another possibility. Great.
Yeah, I also said optometrist or her general physician to maybe refer her to an optometrist. Is there anything else, Professor?
Yeah, I think we're definitely gonna talk more about it later. But the difference between an optometrist and behavioral optometry, that's cool. Something that I have a lot of experience and respect for. The other thing that you might want to consider is starting to connect Sophie with a therapist now. Because as she ages, there may, be those frustrations with socialization. And of course, as OTs, we will support that engagement in occupation. That's going to be really important. But the earlier that we can, and more frequently that we can give Sophie a safe space. So if it's with a licensed clinical social worker or, many of the different types of therapists, that would be a good connection to make. And I don't think that a lot of people know this, but a lot of times in school systems, especially, like Sophie right now is in kindergarten, so she wouldn't be eligible for this. But as she ages, I think it's around middle school, a lot of schools will actually partner with a mental health facility in the area that will provide a therapist to the school. And students at school can actually go for counseling during their school day. And it's free of charge. They do bill insurance if you have insurance, but there's no copay required. And oftentimes, even if you don't have insurance or your insurance doesn't take or isn't accepted by the therapist, they still will cover the cost. That's part of the school. So you may want to check and see if that resource is available, because a lot of times with parents, they're not able to facilitate after school appointments. So the more resources that we can kind of help them find while they're at school could be really important. The next question.
Sarah, is that only for students with an IEP, or is that any student?
That's any student.
Okay.
Really, I think it's a really amazing service, especially so middle, we talked about typical development, and you get into adolescence and high school, and there's a lot of really big questions that children tend to ask themselves, and they don't, it's also made difficult with the fact that they don't often go to their parents to ask questions or going to their peers. And their peers aren't the most reliable source of information because they are asking those same questions. And so with all of the issues that our children face today, now that are heightened with things like bullying, self-injurious behaviors, suicide, online bullying, it's just a really great resource, and not a lot of people know about it, but it's good to connect them with. So it's for anybody.
Okay, thank you.
Yep. So let me go back. Okay, and the last question is, how might the OT and team work to help Sophie and her mom meet these challenges?
So we can work on visual scanning skills and eye-hand coordination, as well as visual motor. We can teach the strategies to her mom and her teachers and kind of collaborate about different compensation and adaptation for when she's in school, and, for the mother to carry over at home so she can keep practicing.
Very good. Okay. Let's go back to... So one thing that I want to talk about briefly before we get into the PowerPoint, excellent job on the case study. Good job kind of sinking into what the experience is like, and what some supports they may need. But the blind and deaf community and the hard of hearing community, especially, that is an identity for them. So this is an example of a diagnosis that may prefer identity first language, meaning that they want to be referred to as being blind or a blind person. They don't prefer an individual with blindness. And they're actually, I've met individuals who are very protective of that identity. They get very upset if you try to use person first versus identity first. This is a situation that it's always best to ask how somebody prefers to be referred to, and, if they prefer identity first language or person first language, because you may run into somebody who actually, prefers person first. I haven't met them, but that doesn't mean that it's just good practice. It's best practice to ask. But definitely, those are two communities that I really have noticed a strong preference to identity first language. Has anybody else noticed that?
I actually have a patient who's deaf and mute, so I think I might ask her. I never have. Or I may ask her sister, because I'm trying to learn sign language. But that'd be interesting to see what she prefers. Yeah.
Kelly says that she has a friend who refers to loving her deaf space. Is that right? With her friends. What is deaf space? What's that mean, Kelly?
I think she was just saying that she enjoyed having to like not have to tiptoe, for lack of a better term, around other people. And if she had someone come up to her really upset that her interpreter wasn't there with her, and she was trying to stop him and say, no, it's fine, but he rushed off before she could say anything. And she said to me, you know, now the moment's gone. Now I can't explain to him that it really is okay. So I think she enjoyed having the time together with other people that she just didn't have to worry about, you know, the random incongruities that happened with other folks.
Thank you for sharing that. I find that people who prefer identity first language usually have some type of diagnosis that they can't put down, if you will. So, you know, there's something about that diagnosis that just kind of, it's everything, you know, it touches every aspect of their life. It's not something that there's necessarily a cure for. It's not necessarily something that they want to cure. Maybe they don't, but it's just who they are. And so diagnoses like, you know, that cause deafness or blindness seem to be one of them. So before we get into the PowerPoint presentation, I do want to mention that next week, I'm going to be doing a test review for the final. So we'll be doing similar to, I think, the first test we prepared this way, where we went through, did some pop quiz kind of questions. Those questions, you know, you could expect to see them again. But I feel like it'll help orient you to the information that's going to be on the test. So if you are not scheduled for next week's call, be sure that you watch the video, because that will give you a lot of really good information and help organize you for the upcoming final. Any questions before I begin?
I forgot to ask you, how many pages does the intervention have to be?
There's not a min-max for that, as long as it contains the information that's required.
Okay, thank you.
Sure. I find that typically, I think the last time it was somewhere, it really depends on how people format it too. But I think last time it was probably between like 6 and 10 pages, depending on format. So, but I'm not going to be looking at the amount of pages. So, any other questions before we get into the PowerPoint?
Or we just can use the table instead of having a paper.
Correct. You can use the table. That definitely is helpful for me to be able to locate information. So,
do you prefer the table?
That's a great question. I prefer the table, yes, but I do have people who work best when they separate the table out, and I've actually been, you know, I've seen a couple of examples where people did not use the table, and that's okay, but they did organize it so that I could also easily locate information. So they had things kind of like bolded and bullet pointed, just to really make their information stand out.
Okay.
Good question. Any others? Miriam says, okay, so yes, you should use third person. So referring to yourself as Miriam. You're welcome. Any others before we get into the PowerPoint? Okay, we are going to get through what we can get through tonight. So go to the PowerPoint. Tonight we are talking about vision and hearing. So the brain pathways for both vision and hearing of these senses are immature at birth and develop normally only when stimulated. So I'm going to pause here because I have a very important question to ask you. what is the best way to stimulate these senses with children?
Play.
Play. Yeah, you pass. You're good.
I don't have to take the final.
You don't have to take the final. Yeah, that's right. So play. Yes. Yeah. Play is the best way because play is the primary occupation of children. Excellent. Back. Oh, yes. Play is the best way to stimulate these pathways. They are underdeveloped. As we remember from learning about development, the first 2 years is our time of tremendous growth. And for children who are either deaf or blind or are vision impaired or sight impaired or are hard of hearing, those areas can be impacted because sometimes people don't know how important interaction is with the other senses. So when we're talking about hearing, it can be expressive and receptive. So expressive means more the way that you respond to hearing. So it could be facial, it's your understanding of hearing, it's putting together some form of response. And receptive is the way that you hear and the way that you process that information. So when we are looking at issues with hearing, it's important to note that we could be talking about receptive or expressive. Problems in these areas can cause difficulties in language and speech, social emotional development, literacy, and learning abilities at school. If the loss occurs before 2 years of age, language and speech may not develop spontaneously unless identification and intervention begins prior to 6 months of age. And I'm going to pause here again. It's because this is a big area of debate in the deaf world or hard of hearing world, specifically with infant sign language. Does anybody here have any experience with infant sign language? No? So I definitely, every single child that I've had myself or nannied long-term, I've taught them infant sign language. Caitlin's Limited. So Kelly says, when I babysat in high school, a few parents I work for taught their kids some sign language. Yeah, it's amazing. It's nothing short of miraculous. My son, when he was 4 months old, was already using the sign for help. And so it just removed so many frustrations of communication because he definitely knew that he needed help. He knew that he wanted interaction in something. And it gave him a tool to use because at that point he could not verbally communicate. But in deaf world, there's definitely a debate on whether or not you should teach your child sign language. And my personal opinion is that you do a disservice to your child if you don't teach them sign language because it's a tool for interaction. And that interaction, and that, you know, if it's at interaction with objects, interaction with people, interaction with the environment, is so stimulating for the brain that you risk not providing opportunities to help all of those senses develop. You know, obviously it's really personal for each parent. When within the community, some of the strongest resistance has actually come from other deaf people. So that's interesting and just important to note. So we'll go back to the PowerPoint. So it was not federal law until 1999 that all infants born in the U.S. had to be screened for hearing. Prior to this, children were not diagnosed with hearing loss until they were between 3 and 5 years of age, and typically there was a loss of language development. Right now, currently, children can be diagnosed by 3 months old if it's congenital, if it's something or it could be trauma from birth. They can be fitted with hearing aids, given early intervention, and with speech therapy, they have a great chance of being able to develop typical language by 5 years of age. With early intervention, what's really cool is that when you initiate early intervention services, that will start pretty rapidly. I mean, like I said, this can be diagnosed by 3 months of age. Not only are you getting speech language, but you're getting OT, you're getting a developmental specialist, you're getting all sorts of services that really help to support development. Early intervention also helps to provide children to access to technology. Again, important to note, this is a real area of controversy. Some people will advocate for the use of hearing aids or the exploration of cochlear implants, and some people don't want that. And there's also other assistive devices that they could use, which we'll talk about in a little bit. And as with any intervention, but especially early intervention, as a reminder, it's strengths-based, letting the family or encouraging the family to make informed choices based on who they are as a family. And this is just kind of repeating, all infants undergo that screening by 1 month of age. They often can be diagnosed by 3 months, and intervention can start actually earlier than that. So, but this is the goal, to have early intervention start by 6 months. So there's different types of hearing loss. It can be conductive or sensory neural. So if it's a conductive hearing loss, it's dysfunction to the external or middle ear, and it can be caused by multiple factors, such as middle ear infection or earwax occluding the ear canal. But if it's a sensory neural loss, it can result from inner ear malfunction of the cochlea. Your hearing loss could also be mixed, a combo of both. And again, it can be congenital or acquired. So minimal hearing loss is a loss of 15 to 25 decibels per hearing level. Mild hearing loss is a loss of 26 to 40 decibels for hearing level. And at this level, a child may miss speech at typical conversation loudest, but moderate hearing loss is from 41 to 55 decibels per hearing level, and conversational speech will sound like a whisper. Other types of hearing loss could be middle ear disease, so a middle ear infection. There are links with this type of hearing loss, which is CHL, which just going back here is conductive hearing loss. So when you see CHL, I'm referring to conductive hearing loss. When you see SNHL, it's sensory neural hearing loss. So conductive hearing loss with middle ear disease, trauma can be SNHL or CHL, and noise exposure can be SNHL. This is the type that my 22-year-old son definitely experiences because he blasts his headphones too loud. I think I told you, I'm not sure. I think I told you the story. So it kind of goes along with that comic. If you don't like peas, don't put them in your ear next time. But did I tell you guys the story of my sensory play table with the popcorn kernels? No. Oh boy. So, okay. So I told one class and not the other. All right. So section 2, apologies in advance. So yeah, years ago when I was a preschool teacher, that's how I really kind of got started on everything. I had a sensory table before I knew what sensory was. And I had popcorn kernels in it, and I had a child in my class who had 2 deaf parents, and while they were in class with me, had concerns that their son had gone deaf. And so they went through the whole they were concerned. They, scheduled an appointment with an audiologist, and their doctor, and they took their son to their doctor and come to find out that he had put popcorn kernels in his ears from my sensory table. So that literally can happen. Always watch your sensory table. Oh, he was hearing impaired, but he was not deaf. He just had popcorn kernels in his ear. So. There are some different diagnoses that are associated with deafness, and I have them here. So such as Down syndrome, but just know that with like Treacher Collins, some of these diagnoses are associated for hearing loss, and interventions for hearing loss include early intervention. Again, can include OTPT, speech language, amplification, hearing aids, cochlear implant, different options for language learning, such as ASL, total or whole body communication. A really popular device that's used at school are FM systems, frequency and modulator systems. And what happens in these, you'll see right here, the teacher wears, or they can wear it or they can put it on their desk, a little microphone, and that microphone is fed directly to a receiver that is with the student. So if the student has hearing aids, and depending on the model of the FM unit, it can feed directly into the hearing aid, or you can wear headphones. This is a really great device for the classroom. However, just note that it can be noxious to some students because you get a lot of feedback. You get a lot of environmental sounds. If you have a teacher who breathes, through their mouth, that's going to pick up. And so at a sensory level, be aware that it's maybe dysregulating. It's very helpful, but it can be dysregulating. So somebody who's using an FM unit could require a couple of sensory breaks just to help them navigate through their day. There are hearing aids as well, a lot of different styles of hearing aids. So this depends on the state as far as what's covered, how many times it's covered. Some states and some insurances don't cover hearing aids at all, and especially after the age of 18, which is absolutely frustrating for many people who have hearing loss. Important to note that there was just legislation that passed through the House and Senate, and I believe the president signed it, to allow hearing aids to be made over the counter. This is huge because it will actually help decrease the price. And maybe in pediatric world, this isn't going to have as much of an impact, but with those of you who work with older clients, this is going to have a tremendous impact because a lot of times, like now, hearing aids are probably between $2,500 and $4,000 out of pocket for adults. And with hearing aids being made available over the counter, that price is going to drop to like maybe $100 or $200. And so these devices will be more accessible to a more diverse population, which is awesome, amazing. Another type of device is the cochlear implant. This is for severe or profound hearing loss. You can get this at as young as 12 months. And you have to not have any nerve damage. That's really important. But you're definitely going to need therapy with how to hear, introduction. You're going to be working with children who have never really heard all these sounds in their life, and all of a sudden they can't tune anything out. So think of how you kind of interact with the world now as an adult, and there's probably noises that are going on in the background that you don't have to pay attention to, but somebody who's hard of hearing or deaf and is fitted with a cochlear implant, they're not going to necessarily have that knowledge, and so it could be very dysregulating and very overstimulating. And there's a high percentage of people who don't use their device as intended because it's so dysregulating for them. So that's something, again, important to note. Oh, and it's a surgery. So there's the cochlear implant, and then there's a, oh my gosh. Oh, I can't remember. There's another one that is actually like a post, like a little rod is kind of drilled into the base of your skull, and you like screw the hearing aid on. These all, like, you have to keep them clean. So there's a lot of education on how to keep them clean and maintain those areas. So we talked a little bit about already. So what are OT intervention areas? One thing that I want to highlight here, a lot of people don't consider sensory, and sensory is so important. When you have either a loss of hearing or, you know, if you have an assistive device that allows you to hear, it's so dysregulating. But if you can't hear, think about the hypervigilance that has to be, you have to have with your visual systems. It's really mentally exhausting and can be very dysregulating at baseline. So make sure that when you're interacting with clients who may have some kind of hearing loss, that you consider sensory. So here's two little buddies playing. One has a hearing aid. The most typical design for children is over-the-ear hearing aids, and they have a mold that fits in. As you age, you could either have just an in-the-ear design, or a different type of mold could be, it's called a tulip, and you kind of put it in your ear canal and it pops open and it stays in place. It's important that this mold fits well, or they will have frequent ear infections, and definitely learning how to clean it. And this little buddy right here has a cochlear implant. Again, making sure that you know appropriate care for a cochlear implant, but the most important thing is that your intervention be based in play, because play is the primary occupation of children. Hearing loss does not have to impede typical development, place a child at functional disadvantage, or alter ultimate outcomes. Professionals working with hearing loss must recognize and make recommendations based on the unique needs of the family. But always remember to keep play front and center, whatever you do. People who are deaf and have hearing loss enjoy a wide range of things. They hear differently. There's a really cool dancer, a hip hop dancer named Shaheem. If you watch him dance, it'll blow your mind. He's incredible, and he is totally deaf. I believe Niall DeMarco. Does anybody watch, whatever that ballroom dancing show is? Anybody? No, Kelly doesn't watch it. What's
Dancing with the Stars?
Not so you think, yeah, Dancing with the Stars. That's it. So I believe his name is Niall DeMarco, actually won. He's deaf, and he won Dancing with the Stars. So if you have an opportunity to watch some of his dances, it's incredible. People who are deaf and hard of hearing often love to do movement and dance because it does stimulate that inner ear. So they like enjoy seeking that type of behavior. But yeah, I'm actually gonna stop here. You have the notes on vision there for you, but we only have a couple minutes left. So rather than get into a whole different topic, we will pause there. Are there any questions, comments, or concerns that I can answer for you?
I just have a question about the debate for the sign language.
Sure.
I know you said there's a debate why wouldn't people want to teach the sign language?
Because
what's the fact?
they're concerned that it's going to impede speech development. So they're concerned that if a child learns sign language, that they're not going to speak.
Okay. And my close friend, both of her parents are deaf.
Mm-hmm.
And I know they're very against, not like very against, but they are kind of against like the implants and the cochlear implants, I guess, because I guess like the deaf community is so close and it's such a big community that they're afraid that they're going to lose that, I guess, sense of it. Is that like a pretty big thing as well?
Yeah, it's really interesting in the deaf community to watch some of these conversations that happen. Personally, like, you know, I think I've already shared with you that I came from a time where special education wasn't really a widely known thing. And so my parents made the wonderful, I don't regret this at all, but I didn't learn sign language. They put me in a speaking school. So it's really interesting. And a lot of those attitudes and beliefs can be influenced by the reality that before 1975, children who had disabilities were either educated in a different school if they were educated at all. And so it's almost survival. And so it's really hard to get away from that stigma. It's really hard to get away from some of those concerns because, I mean, they're still in our lifetime. It's not like it was 100 years ago.
Right.
So, yeah, it's something I always kind of like to sit back and whenever you work with a different population, it's good to go in and look at some of the conversations that happen within the population because it will surprise you. Like I wouldn't have assumed that.
Yeah. And that's what I was like shocked about, that they wouldn't want to. I mean, that's just like a sense that they've never had before. Hearing, so I guess it's interesting that they would never want it, but I guess, like I said, like they don't want to lose that community and that sense of like this is me, and I don't know, interesting.
Yeah, and it's such a strong, like I said, it's an identity.
Right.
So they're afraid of losing that identity. I have hearing aids. I don't wear them. I don't want to hear, like, a similar thing of all of a sudden I started hearing things that I don't want to hear. So
yeah.
that was my reasoning. It had nothing to do with identity. Just like I had no clue how noisy plastic bags were. So, any other questions or connections, or do you know somebody who has this experience?
I guess I also have like another question. I know you said you're functionally deaf. What is that? I guess what does that mean exactly?
Sure. So I am profoundly hard of hearing. So I can hear sound, but I have a lot of issues with receptive language. And so I can hear the noise, but it doesn't make sense to me unless I'm reading your lips or I have closed captioning.
Oh, okay.
So, and in a way that's a benefit because I don't hear all noises. I'm still profoundly hard of hearing, but I do hear some noise, and that's very helpful. But I don't hear high ranges of noises. There's a couple times, well, I won't tell you what movie, but recently I saw a movie, and there was a situation in which they used a very high pitch, and I noticed everybody around me cringing. And I was like, oh, like I don't hear it. Like I hear it all the time because I have tinnitus, and so that's what it sounds like all the time for me. So I just didn't hear it, and I noticed like my daughter kind of like going like this. I'm like, oh, there must be some high screechy sound.
Yeah.
Yeah. But yeah. Any other questions? Okay. Well, then that's it for tonight. Again, I know it's late in the semester, but I really, really, really please watch. If you're not participating in next week's call, please watch next week's call because that will really help you orient yourself for the test and prepare for the test so that you can be successful. But otherwise, I will see you next week. And if I don't see you next week, I will see you end of the month.
Thank you. Good night, Professor.
Good night.